conducting community outreach and understanding what our residents think or what they would like to see. The next goal would be to develop short-term and long-term plans to address the identified public health needs. The third goal, which I haven't really mentioned to anybody, but pretty much it would help us consider the application for accreditation by the Public Health Accreditation Board. That's one of my long-term goals, to get our health department accredited. And the fourth goal will be to use the report in support of grant funding specific to the needs identified in the assessment. So the company or the individual we end up contracting with must deliver a complete community health needs assessment document to the board. And they also have to deliver a complete community health improvement plan. In terms of the community health needs assessment delivery, they would have to manage the project and engage appropriate partners to participate. They will have to conduct a primary and secondary data review. They would perform key informants interviews and focus groups. They will conduct a community survey of the town of Reading. They will draft the assessment for review, and they will also facilitate the prioritization of the assessment results. Once they do that, they're ready to deliver a complete community health needs assessment for the town of Reading. Once that's done, we expect them to facilitate meetings for the development of a community health improvement plan. So we don't just want them to identify the needs or the issues. We want them to come up with a plan that would help us address those issues as well. And then they will be tasked with drafting and finalizing the community health improvement plan. We would have to make sure they facilitate meetings to draft a work plan for at least the year one action plan. So we're not asking them to stay with us forever, but they should try to lead us in the right direction. Mm-hmm. So, and this is just from my perspective, okay? The project timetable is between November 3rd and December 5th. So these dates, if the board wants to change them, that's fine with me. I just came up with them because usually around November, December, things are a little bit slow in all health departments that I've worked at. So I felt like it would be the time to get this done. So we're looking at November 3rd at 11 a.m. for all the proposals, the RFPs to be due. So everybody has to turn in their RFPs, their proposals by November 3rd. And then the week of November 14th, we will conduct interviews and reference checks. And then by the week of November 21st, we would notify, we'll pretty much issue the awards. And by December 5th, we would provide a notice to proceed. Project completion and deliverables are due later on. The board would have to determine that. My recommendation would be to not go over 6 months, but it is ultimately up to the board. So again, this RFP is a draft. If the board would like to make changes to the draft, please let me know, and we'll go from there. Thank you very much.
Kevin.
I've read through it today. It looks like it's a really well written document, and it looked like it's very favorable for the town. The only question I had is the one that you just raised, at the timeline for people to submit. There's quite a bit of information that companies have to get in there. in your experience, you think about, roughly a month is enough time, granted, or should we push that maybe a couple more weeks, maybe mid-November?
Well, I think a month should be enough. There are not too many companies that do this, so
Okay.
yeah,
And the ones that do have all their stuff keyed up and ready to go,
they have everything ready.
typically.
Correct.
Okay. All right. That's the only thing I had about it. Yep.
Yeah, that's my experience as well. So, yeah, I think a month is generous, in fact. Okay.
I had a couple questions. One is just in terms of, because we had this issue, I vaguely recall last year when we did the internal consult, was that we didn't get a whole lot of responses.
Right.
And so, and you mentioned there aren't a whole lot of people who do this kind of work, consultants. So where would we post this RFP, and are you confident that we'll get at least a handful of these, or what do you think?
Absolutely. We would post them on the combis for the state of Massachusetts, and we will definitely get people that are interested, people or organizations or companies that are interested in performing the CHNA for us.
Okay. And the other question I had was, the RFP mentions a selection committee. And I'm wondering what your thoughts are about how the board can engage with a selection committee in terms of going through the applications and making a selection or a recommendation to the board.
Well, this would be this is a purchasing department protocol, but I'm sure there's a role for board members to in the selection committee, and I can get more information and see how they can work with the board to select the right candidate. But the rules are set. They have to go by everything listed in the RFP, and I'm not sure if the board involvement is going to make a difference.
But I think it's, go ahead. I mean, I think it's important for one or two board members to be involved in that process, because the selection criteria that were listed in the RFP, although it's an attempt, and I think they were very similar, as I recall, to last year's, it's an attempt to be somewhat quantitative, but they're very qualitative. And so that means that the selection committee will need to interpret those. And I think having one or two board members, I think if we had an associate and a board member, we wouldn't have a quorum. I think we could get by the open meeting law issues on that. Oh, Kevin.
I don't think
We can't.
No, because there could come a time where this comes obviously back before the board, and that associate member may need to be a voting member.
Oh,
right.
okay.
I see a role for the board to play in the interview process. I think it will be limited to the interview process.
Okay. Okay. Well, I think that's important, because if we have in terms of your time frame, if the applications for the RFPs come in the month of October, and then the month of November is the selection process, I think it would be good for at the December meeting of the board, maybe there's a presentation by the final applicant, or if the selection committee is struggling between two, perhaps both. But I think it would be nice to have some opportunity for input at that time, so we can talk about that. I mean, I don't have an issue with the applications being done by the first week in November, and then narrowed down to a finalist or two finalists, whatever. But I think it would be nice to have, for the December meeting, to have some brief presentation, so we kind of get familiar with who we're going to be working with for the next 6 months.
Absolutely.
Well, and if I may, Rick, I mean, so that fits, and Ajay, I think you crafted your timeline well and intentionally with the notification to proceed on December 5th, so that a selected vendor would be eligible to come and speak to the board as the selected person. Obviously, if there was a or selected organization, obviously, if there was as Rick says, if there was either a lack of applicants or a challenge in a difficulty in clear selection, then your timeline may be impacted. But I see that fits well. I agree with you, Rick, that I think it would be valuable to have some input, and I like the idea of being able to participate in interviews.
Yeah.
And I will volunteer myself if I can. I have to, but I will volunteer if we can talk about that later, but I would be interested in participating.
Good.
Can I
Yes.
ask one question and give one request? So under the project goals, can we change the statistical view to the epidemiologic view?
Good.
Is that word?
Thank you, Terry.
And then my question, and this is something we may not have an answer to, but if we are going to ask them to put together a plan, are we also asking them to quantify the finances that would be needed to implement that plan?
So right now, we pretty much have about $30,000 set aside for this project. We're not sure exactly how much it will cost, but we're so blessed in the town of Reading that if it goes above that, we have the opportunity to request more funding. And if I remember correctly, I think we were awarded by the finance committee. They gave us about, was it $250,000 of ARPA funding last year? So we have some funds left. I think we have about $160,000 left that we can use. So if we need to get additional funding, I can go back to them and request some more funding.
Yeah, no, it's just something to think about.
Don't tell the applicants we're flush. They don't need to know.
Oh, this is a public meeting.
Yeah, I sorry, Rick, if I may, just to build on what Jerry was saying, to the extent the recommendations could include estimates of what costs may be for going forward in implementation, that would be very important, because otherwise we're going to end up having to go out and get the info. So yes, that would be helpful, but it's hard to know because you don't know what the recommendations are going to be.
Correct. But the good thing is it's an RFP. So we're looking for the person that meets the qualifications and would cost us the least amount.
And is that we have to take lowest bidder unless their application is not responsive to
Correct.
our criteria.
Correct.
Yep.
Then we go to the next step.
Yep.
Yeah, I mean, in theory, we can take the most advantageous if they meet all those categories with that declaration. That's a little bit higher than somebody who is less advantageous.
Correct.
Which would be my preference.
Yes.
If it comes to that.
Right.
Same here.
Prioritize. Yes. Prioritizing quality. Yes.
Yes.
Okay. So I'm sure if people have any other comments or questions or suggestions, they can always email a day. And but otherwise, sounds like we're pretty much ready to go ahead.
Okay. So just one more comment. I would like to, get this to the town council sometime next week, or maybe a week from next Monday. So if I can get all the feedback next week, that would be great.
Great. Okay.
Monday's a holiday.
Monday's a holiday, a
We can
weekend.
take care of it then.
Okay, let's move on. And what Ade and I have been talking about the fact that would be a good idea for us for the board to kind of see where we are with respect to all the recommendations that MAPC made last early spring, back in April. And so you all saw that dashboard, but I'm going to try to put it up on the screen for the public and walk through it fairly quickly. And we could see if there are any other comments or discussions. So as you recall from their report to us at the time, there were 4 strategic goals, and each strategic goal had some specific items under it. And so this is set up so that you can see what the objectives were. A completion date, which they didn't give us, but we kind of plugged in. Who was the point person on it, what the current status is, and just for those who are visually adept, and a sort of red, green, yellow, meaning that red is not started, yellow is started or in process, and green is completed. Mm-hmm. And so, so they recommended hiring an experienced public health clerk, which, as Ade said, has happened. Unfortunately, she's out sick today, but Melissa Touton will be with us in coming meetings. And that was a key hire. The idea was to have Jennifer be certified as a sanitarian, but it does take apparently 24 months of experience before you can sit for the exam and become certified. So that's in process, but obviously it's on our way. The software for tracking, permitting and inspections and so forth has been implemented. We're going to be talking a little later tonight around the town meeting next month around advancing Article 11, which would expand the board to 5 full members. So that's in process. And we hired Mallory. And so that's green as well. So making good progress there. In terms of skills and capabilities, they recommended that Board of Health members complete the Foundations of Public Health course. I know that Carrie and I have completed it. I think Paula had said that.
Not quite.
Not in process.
Right. In the process. Yep.
Yeah. So we're kind of on that way. And then there's a certificate training by MAHB, which I think Carrie's completed. There is a virtual course October 13th, which I tried to get on the website, and the more information was, when I clicked on the link, was password protected. So I'm not sure what that means. I'm hoping that it's open to members and non-members. And so is it Carrie? Well, Carrie, you're on mute.
We're all members by virtue of our role.
Oh, okay.
Yeah, so I don't know, maybe a day had a chance to figure out what the block was, but
We'll take a look at that. But if you can make that, that's it's an evening, I think 3 hours or something.
I am away next week, so I cannot.
Okay, but they offer this periodically, and so
okay.
We have some time. And then, as Ade mentioned here, there is a development plan underway for Jennifer and Mallory. We've developed some regional efforts with the Shared Public Health Services Grant, which we'll hear a little bit about momentarily. And we talked last month about the Regional Tobacco Preventive Collaborative, which we rejoined. And by the way, I guess the updated tobacco regulations weren't fully completed. Hopefully we'll be able to see those next month. A day is trained in ICS, Incident Command, and I believe Mallory and Jennifer are underway in that. And all the staff have joined their respective associations, so that's great. There's a couple work groups, the Hoarding Task Force, the Incident Command, that meets this need, and we talked about the shared grant. And then opportunities to engage. So these two, I feel we're making progress, but I'm not sure I would say we're there. I think that we have done some work in both cases, engaging and communicating as listed here. But it might be a good topic for a future board meeting about what we could do in terms of social media, in terms of the website, in terms of, I think like for this first one, what MAPC had talked about was, each month is designated, Breast Cancer Awareness Month or Hypertension Awareness Month, or, and for the board, the health department to perhaps have an event or do something specific on a kind of regular basis. And of course, coming out of our community health needs assessment, there will be some priorities that we'll want to. So I think we're working towards that, not quite there yet. Where we talked about the needs assessment here, underway, and Ade is working on getting this cultural competency training set up. So, what's very positive and satisfying actually is that we've made headway in a lot of these recommendations. Are there any comments, questions, feedback, suggestions, anything? Terry?
Thanks, Rick. And thanks for running us through this. It's really helpful. And I for one, am a big fan of the red, green, yellow.
Yeah.
So are we including our associate members as people who would be doing, the foundations or the MAHB training as well?
You should. I've been dragging my feet, but yes, you should, because they could be elevated to voting members.
Yeah,
Right.
I would hope so too.
Okay.
Okay.
Okay. Yeah, just because there was the one way it was phrased. I just wanted to get clear on it. But
Yeah, that was a little vague. I agree.
Yes.
okay. Yeah, great, because well, and I'll say I did the MAHB training. They really do a very nice job. I think the abbreviated version would be good. If it doesn't fit schedules, that's too bad. But they do offer regularly. And
Yeah, I can get there next Thursday. That's good. I did go on the site the other day looking for more, or the next courses, next round coming up for the foundations. I couldn't find it.
So foundations is actually offered in a it's asynchronous training, and this goes back to my old job. This is async online training. It's available 24/7, no cost. I know that there was a little shift between learning management systems recently, so it's possible that would be why there was a gap. And Paula, I see you nodding your head there. Yeah.
Okay.
But yeah, it's available. So you can take, and Paula and Rick have done it more recently, but you can take it kind of at your leisure, and you can pick and choose which courses which titles sound the most interesting to you at that moment.
Okay, perfect.
Yeah. Okay. And I'm just curious, with the ICS training, what levels of training are we expecting for folks?
Good question. Because there's like an introductory, and then there's something more advanced. And I don't know if in their recommendations they specified that. So what would we think?
So I would say that there are requirements generally that a public health director needs to be trained through ICS 400 to be able to function as an incident commander. And then, there's a question of what you do for other staff. So I don't know, Ade, are you already 400?
Yes.
Good for you. Good for you. And what about other staff?
Well, I would recommend the same for other staff members.
Yeah. I know it's not always easy to get. I'm actually waiting to get into a 400 class because the timing hasn't been right, and they don't offer them quite as frequently, on the theory that we shouldn't have too many commanders and not enough, staff. But okay, that's great. That's great to hear. Thanks. And the cultural competency, I just wanted to ask, there's an awful lot of work happening throughout Massachusetts at the municipal level and the public health, the emergency preparedness world and the like, on health equity strategies, on applying a health equity lens to all of your practices. Is there something happening in the town of Reading for staff that you envision involving the department with, or are you thinking of other things in addition, or is there not something happening in Reading?
Just to be honest, this is one part of the MAPC recommendations that I've not really paid attention to.
That's fine.
And that's why it's still in the red. I will get to it shortly.
Okay.
And go from there.
And I'll say, I will make myself available, just because we're doing some work from our organization on kind of how do you apply a health equity lens to the work and have some insight. Yeah, no, I understand. It is a big ask. And when you're trying to get all the inspections done and
correct.
it's very hard to pull out time to be able to do that deep thinking for a new kind of, I understand completely. That's awesome that it's on the list. And then just annual communication strategy, was that something that we talked about, maybe working with Jane Wellman if she was available for kind of helping make a calendar, or am I making that up?
I think we had mentioned her as a support to do this, and as I said, we might have this for an agenda item in the next couple months, something around what more we could be doing to outreach and engage the public and do more education. I think where things are settling down, hopefully to the point where that kind of more elective and we're maybe a little bit out of the crisis mode unless we have a surge, and we could start to focus on that.
And to your point, I think you're right, Rick, that the needs assessment will, ought to by right include some of that. So we don't want to get too far ahead of that. Let the experts have their opportunity with us. So, okay, thank you. This is great stuff, great progress. Really nice to see all that green.
Very positive. So we'll update this around some of these comments and feedback, and I suspect maybe in March or April we'll revisit this and see where we are going forward. All right, so update on shared services grant. I asked Ade to, he had announced that we had won this grant with other communities, and I just wanted to find out kind of where we are and what's progressing and what's in the grant and what the time frame is and so forth. So I turn it over to you, Ade.
All right. Thank you, Dr. Lopez. So as you may recall, the towns of North Andover, Reading, North Reading, Linfield, and the city of Haverhill secured a Public Health Excellence for Shared Services grant in the annualized amount of $297,200 for a minimum of 3 years. At this point, we are waiting on a fully executed contract from the state by the end of the week or early next week. Once received, we will have our orientation on November 2nd. In the meantime, we have signed and submitted the municipality statement of commitment. I believe that I included it in the packet for the board. And basically what that means is that we agree to cooperate with the lead municipality, which is not Andover, to ensure compliance with the scope of services. It also means that we agree to use the funds provided under this program only to augment rather than replace current municipal funding for public health staff or services. So we're not gonna, get rid of staff and use the funding to hire new staff. That's not the purpose of this. Also, we have drafted a job description for our shared services coordinator. We, the health directors of the towns involved, believe that we need a coordinator to help us manage this grant. The coordinator will be based in the town of North Andover's health department. The coordinator will report to the Shared Public Health Services Board. And that will be comprised of the public health directors from each participating municipalities. So we will be the board. The coordinator will work on a regional basis to ensure coordination, support, and delivery of shared nursing, inspectional, and epidemiological resources for the participating health departments. The coordinator will lead efforts to secure resources for ongoing work of the shared service initiative. And the coordinator will perform other duties as required. Let's see. So that's pretty much all I have for the shared services grant. Once we get through the orientation on November 2nd, update at the November meeting.
Pretty excited.
So we haven't defined the shared services yet. That's coming. The directors are working on what specific services might be shared across those communities.
Correct, but we know that we're going to have inspectional services, we're going to have epidemiological resources, and we're going to have nursing services as well.
Okay.
So we're going to use the funding to hire an inspector, hire a public health nurse, and hire somebody that does data, and also hire a coordinator to help supervise those people that we hire.
Great. Terry, yeah.
I saw Carlo had his hand up first, though, I think. Did you have something, Carlo?
I just have a quick question. Thank you, Kerry. Thanks, Rick. A day, is that, you said 3 years, is that per year or the total of 3 years?
Yes, annualized amount. So $297,200 per year for a minimum of 3 years. So we're looking at around $900,000 for the 3 years.
Wow.
And then I'm guessing you can apply for it again to sustain it?
To renew it, yes. We have to meet
apply, you have to apply again, right? You have to apply again.
Pretty much.
Yeah. Okay. Well, that's a lot of money. Okay, thanks.
Yes, it is.
There's a if you're in the field, there's a shocking lack of public health services across the Commonwealth, and there's been decades, 2 decades of advocacy at least to get attention paid to that, and that the result of that advocacy is finally some funding to address these gaps through these shared services grants. So it's a huge victory for the Commonwealth and for the health of people. And, shared services means that there will be more common practices across communities. I know, Carlo, particularly, that was something you and I talked about when I interviewed, kind of the challenges of having different rules or interpretation of things being different community to community. And that's something that has, caught the eye of with the shared services work as well.
A good example of that is the tobacco program. So everything will be standardized amongst the municipalities involved, which is great. So if you're having issues in Reading, you're not going to run to not Reading to go and buy cigarettes because they have a different set of rules. So there's
Right.
some kind of standardization
Yep.
with shared services.
So Ajay, I'm curious about the staff that are getting hired. Are they all going to be employees? And are they all going to be employees in North Andover, or are they contract roles?
They won't be employees for the town of Reading.
Right?
It will be for Andover.
Andover will be the hiring organization.
Correct, because they are the lead municipality.
Got it. But with the understanding that they're hired to serve the group of communities. But so
Correct.
they're all our employee roles, including the coordinator role?
Correct. And
Okay.
their salaries will be based on the availability of the grant.
Okay. Right, because it's annual, right? Okay, great. Very exciting.
Yes.
All right, thank you, Aday. No other comments, we'll move along. One of our favorite topics, COVID. So what, at our last meeting, we had, I need to set the context for the conversation. So at our last meeting, we had a couple residents make public comments, and they were, interestingly enough, they were on sort of opposite ends of the spectrum around how to approach what the board might do, with respect to interventions around COVID, should there be a surge going forward. And, it reflects society at large. And I thought that it would be, I think a couple board members, we really should talk about this. And so this, I think, is to have an open conversation without a vote, without, necessarily reaching a decision, but it would be useful, I think, for the board to get a sense of where the board is around over the next few months, how we ought to be thinking about our response to COVID, beyond, vaccinations and tracking like we've been doing. And so I thought we might just spend a little time in a kind of open-ended discussion, no votes, no firm decisions, just a sense of things around, specifically around, over the next 3 to 4 months, if in fact there's a surge like there was last winter, what are the things we ought to be thinking about? And so I'm going to share my screen again because I have a couple items that I want to go over. So, let's see, where are we here? So the good news is that using the state data, we're sort of at a low level of activity. And this was the surge last December and January. And our numbers have been fairly stable the last couple months. And this is around 11 or 12 cases per 100,000 on average daily cases, which for a town like Reading, that means 3 or 4 cases a day. And it's been fairly steady. So that's sort of the positive piece here. In terms of the cautionary is the wastewater tracking, which is showing, this was way back during the surge, and the tracking of the virus or components of the virus in wastewater, and this is for the North MWRA. It was a low level through the summer, and it has started to tick up. And our past experience has been that this is this sort of moves ahead of what tends to track in terms of cases. So there's sort of a progression of indicators. There's the wastewater tracking tends to go up first, followed by the case counts, followed by the hospitalizations, followed by the deaths. And that's been the general trend. So, there's good news and bad news. And right now there's a fairly low level. One of the questions that's come up is how we should think about what our action should be as a board, and with respect to COVID and the cases. And so the CDC published on August 11th a set of new guidelines, which are summarized in this table and the next. Where they divided COVID activity and they defined it as low, medium, and high based on the COVID cases per 100,000 in the past 7 days. And then sort of subdivided looking at admissions and percent of hospital beds used. And this is per county. So it looks at it per county. And so currently, Reading has, if you calculate it based on, number of people in the last 7 days, it's something like 80 to 90 cases per 100,000. So we're very much on the low side there. And so what the CDC did was to say, we're going to define across the country by county, low, medium, and high, and we're going to update it. I think they update it weekly. And currently, Middlesex County is rated as medium level of COVID activity. And that's because if you look at the numbers, Middlesex County has this case rate is actually 122 per 100,000 people over the last 7 days for Middlesex County. But our case rate in terms of admissions is 12.5%, which is in this range. And the percent of inpatient beds is actually 3.5%. But because of this number of admissions per 100,000, it bumps Middlesex County up to to medium transmissibility, which is pretty much most of the state. The CDC went further and said, okay, based on whether your county is low, medium, or high, we have different strategies of what we might do to address COVID. So if your community level is low, there are certain things an individual might do, and there are certain things that at a community level you may want to consider. And then there's, same for medium and same for high. The CDC cannot make mandates in terms of community activity, and so they are all recommendations. And unfortunately, I think, because they're recommendations, one can look at them and interpret them in different ways. For instance, you could look at this statement that is on the CDC website and say, really, masking is a personal preference. And then you could look over here and say, well, if it's high transmissibility, you may want to wear masks all the time or mandate them. So you can, on the same page, you can interpret these things in very different ways, which, kind of leads to confusion, but, this is not a black and white type of situation. To make it more interesting is that when you look at the county data, and let's see if I have it here. I thought I did. Maybe I didn't. Hold on one sec. Let me pull that up. Here we go. So if you look at Middlesex County, which is right here, and this is for last week, what you can see is that although the CDC guidelines create high, middle, and high, medium, and low COVID activity by county, within the county, there is a lot of variation. And so some, cities and towns have the darker blue have very higher rates, and the white here cities have very low rates. So, there's a lot of variation. I wouldn't expect the CDC to do a town by town or, regional demographics. I mean, that is just too complex. So I understand why they did county by county, but there is a lot of variation within the county. And so basically, the question, and I know all this was sent out to the board and I believe had a chance to peruse some of it, but I think the question is, as we think about COVID and the potential for a surge of some nature, how would we want to react to that in the winter months, should that occur? And I don't think we need to reach a decision here today or be very specific, but I'd kind of like to get a sense of what board members are thinking around how we should be reacting. So for instance, I think last winter, we were a little bit late to the game, perhaps, in making a decision, having a hearing, and deciding on some actions to take. We were sort of well into the surge at that point. It'd be nice to not to have that, not to be late to the game again. And so, my general feelings, and I'll say what I think, and then I'd like to hear from all the board members about their thoughts, is my thinking is that the CDC has a reasonable format schematic of how to think about this. It reports the data every week, just as we track it here, and Massachusetts Department of Public Health tracks it as well, and it's available every week. That we ought to, track the data, that we ought to broadly follow the CDC guidelines, and that, but I think we need to make decisions based on sort of at the moment of where things are heading, and it might mean calling an extra board meeting or two, to have a discussion about what we ought to do. I think one of the residents had suggested, sort of an automatic orders that might happen, if there was a certain level of transmission, if we went to high by the CDC standards. And I think, with that much variation in the county and with the importance of those kinds of decisions, I would want to have a board discussion personally before doing anything, as opposed to creating an order that just automatically happens for any type of intervention that we decide. So those are my thoughts. It's a little vague, but I would say try to follow the data, anchor on the CDC guidelines, and try to be timely in acting in whatever way we feel we need to, and not waiting from month to month to a board meeting and then falling behind. So those are my ideas about how we ought to approach this. But I'd like to hear from board members about you know, what do you think we should be doing in the next few months in terms of reacting if there was an increased number of cases? She just mentioned that, you know, last year COVID was the third leading cause of death. And Massachusetts reported today 46 people died of COVID last week. So it's low level of activity, but it's definitely still with us. Fortunately, we haven't had a death in Reading, I think, since last January or February was our 53rd death. So comments, thoughts? Jerry, I can tell you're right there, ready to jump in.
No, I mean, I think your approach is sound. I mean, it is helpful to use what the CDC's already published, and I think having Ade on board and his team to, like, you know, bring us together as needed makes sense. I think if there's any plans though to do anything about remasking, it would be nice to be able to make it something like a little more positive and fun. I know that sounds crazy, but almost like a public service thing. Do you know what I mean? So just prepare for that in advance, because we know it's going to be politically charged, you know, to the extent that we can be encouraging and positive, I think would be good. Hopefully it won't come to that. I mean, I think that's the hope.
Yeah. Thank you. Other thoughts? Carrie, you must have something to say.
Oh, well, you know, I do. I'm just holding, you know,
Holding back.
Just want to give other folks the opportunity to talk.
Okay.
I would agree with you, Rick. I think it's makes sense to me.
Okay. Kevin?
I got a couple things to talk about. One factor that's not being taken into play here, which is a huge data set, is severity. This is just simply talking about COVID-19 itself, right? So it hasn't discussed severity. So to me, the severity, you know, i.e. would be hospitalizations, deaths, ICU. That's one of the bigger factors that should be taken a look at. So, for example, there's a case where, and we will have a surge this winter. I mean, it's inevitable, because people are going to come inside. They're going to, you know, they're going to be gathering with family and friends inside, football, holidays, all of these things, and these are all going to be the big contributing factors as they were last year. And so, to me, severity is something this board should be looking at first and foremost, not just simply a surge. You know, as of last year, and even still going on right now, the severity of this variant, as was the variant last winter, turned out to be less severe than the flu. But we never discussed doing anything about the flu. What if flu levels rose? So, you know, this is where I've always been all along. If you're going to institute something like you did last year with a mask mandate, there has to be some level of result that shows it was effective and had more of a net positive on the community. Because what you're going to get with a mask mandate, in my own opinion, and this is just an opinion, is an implementation problem, which is going to result to a net negative in the community. There's going to be division of the community. There's going to be, you're now deputizing every public manager that's going to be out there. And they're going to be calling the police over somebody not wearing a mask. Somebody in the supermarket will be calling the police over somebody not wearing a mask. I haven't seen in the numbers, the graph that I think today that you put together, which was excellent on the spreadsheet, that showed the difference of the ones and the twos, right? So the communities that had the mandate versus the ones that didn't have the mandate, obviously the numbers were higher than the ones that didn't. But I honestly, I didn't see this major net, like, wow, look at that. That's a huge result. That's a big gain for us. It really wasn't there. And again, the severity of it really wasn't there either. And it's even less severe as of right now than it was with the variant from last winter. So to me, it all comes down to, those factors. What's the implementation of something like that look like? And is it going to actually be really a net positive for the town? Or is there not going to be that much difference? And therefore it's going to be a net negative. That's what I would assume it would be. Now, if the severity is through the roof, well, obviously that kind of goes out the window. I will admit that it's getting more and more transmissible, which certainly plays into that argument. But again, if, the common cold is very transmissible. Again, severity to me and implementation are the two biggest factors that should be looked at. I think everything else is politically charged, and I think it is going to be a net negative for the town.
Can I ask a clarifying question?
Sherry?
So my clarifying question is, the CDC data is hospitalizations and deaths, right? So it's not about raw numbers of positivity. Is that understanding correct? So the low, medium, and high is about those more severe cases.
I don't know how they compile their data. What's weighed more, in other words, in their data set? Is there a bigger weighting for number of cases? Is there a bigger weighting? I don't know how they're compiling their information.
Yeah.
But their point in that scientific brief that they published was they agreed with you, Kevin, that severity is an important factor. And actually case counts, because many people have been immunized and have had it, case counts alone is probably not enough. And also the fact that many people have at-home testing, and a positive at-home testing doesn't get into the data, either at the federal level or the state level. And so if anything, the case counts are actually probably underrepresented rather than overrepresented. So what the CDC did was to look at two other factors in that grid, which referring to, which was the number of admissions for COVID and the percent of hospital beds filled up with COVID patients. And hospitalizations, I think, is a good measure of severity. You could say that deaths are even a better measure, but you kind of lost the boat by then. Horses out of the barn. So that's why they look at hospitalizations. But from my perspective, what I struggle with is that Middlesex County is so big that their numbers for admissions include Lawrence and Haverhill and Chelsea, and there's a lot of towns where because of a whole lot of factors, the intensity of of COVID has been worse, either because those populations are under immunized, or they're very compressed, or they're workers who are more exposed. So I think, to your point, I would agree that on the severity issue, and maybe what we ought to be looking at is for the hospitals that surround us, Winchester, Melrose, Wakefield, Leahy, Burlington. I think those are the main ones. We ought to be looking at their activity and not necessarily the activity at Lawrence General or other hospitals that are further away.
Yeah, and I think, to me, if this board wants to institute non-mandatory, in other words, highly and strongly recommend masks, I feel like that's a better avenue. I feel like it's going to work better for the community that way. And I can guarantee you it's going to be a tough go of it if it's a mandate, again, for all the managers in and around town of public facilities. They're going to have a really tough go of that. It's going to be, it's not going to be, I don't think it's going to warrant the difference in the numbers. I just don't. But again, that's my personal opinion. So.
Can I ask another question? Do we think hopefully it'll never come to that, but do we think the public understands that the new data we would be looking at would be different than the old data? Like the old data was about, case numbers, but this new data that we would be using is more about severity.
Yep.
Like, would that, Kevin, do you think change the opinion if it ever came to a mandate?
I doubt it. And I feel like there's the two groups of folks out there. There's absolutely tell me what you need me to do and never again. And it doesn't matter what you present to never again. It's just going to be never again with them, and it's going to be problematic. And I know it's, you're trying to value both sides really, because but from a public health standpoint, you're also trying to make sure you're doing everything you can for the betterment of the public. That's your job. That's your role, right, as voting board members. So it's a very difficult thing to balance. But again, right now, hospital beds are already full up, and we're not even in a surge. So that number is going to go through the roof real fast. And there's not much we can do about that. It seems that we seem to not have enough beds. We are the hospital mecca of the world, right? And it shows. People are flying here to get in these beds. They're not just coming from down the street in Belmont, but they're coming from there as well. So it's difficult. That number is going to go through the roof real fast if there's a surge. It's already high. It's already in the 90% full capacity. That's
but actually, what the data is looking at is the percent of beds due to a COVID admission. It's not the percent of beds.
Okay, so it's not about we want to make sure there's beds for other things too. Okay.
Percent of beds with COVID.
Okay.
And currently in Middlesex County, it's 3.5%. So it's actually a relatively small number.
Rick, did you see any data about COVID being a secondary diagnosis after admission for another ailment?
I've heard about that, and I'm actually not sure how the CDC or the hospitals reporting to the CDC.
Yeah, that was my point in asking the question. Yeah.
Do you know that, Karen? Do
Yeah.
you know if they fixed that problem?
I mean, I know there's still kind of a conversation about it, but there had been some raw measures identified that would clarify, and all the calls I'm on, we talk about primary versus secondary COVID. It's a understood concept. So yes, so secondary COVID being people who are admitted to the hospital, and when they're admitted for something else, they're tested routinely and discover that they have COVID. So yeah, so it is measured, it is reported, and yeah, it's a regular point of discussion. So
Okay.
Yeah, I mean, I think the CDC numbers is percent of beds patients with COVID as the cause of admission, but I'm not 100% sure.
Yeah.
that's my understanding.
So if I could make a point to both Jerry and Kevin, to Jerry's point, I think that we do owe the public the service of educating still. Things have changed. And one of the big things that seems to be changing is long COVID and this surge in deaths that is higher than what would be expected from year to year. And it's not necessarily connected with COVID, but I don't know what else is out there that might be doing this. I could be wrong. And Kevin, I get what you're saying about the people that are not going to change their minds no matter what, but we still owe the public the service of educating them to protect themselves.
Sure,
That's
absolutely.
my feel.
No, I couldn't agree more with that. Yeah.
And the long COVID thing, and we're only just beginning to see that.
And the long COVID is
It's scary. Alzheimer's, look at Alzheimer's. It's going through the roof.
Yep. It is yeah, that risk of the long COVID experience is at least as concerning. Perhaps I'm not going to say more concerning, but it's yeah. This is such an interesting conversation. Yeah,
Can I just, before, I know, Carrie, you probably got a whole bunch of things to say. Can I just ask a question as well, too? I'm sorry.
Thanks,
They're going to
Kev.
probably have the answer for you.
Thanks, Kev.
I mean, with all respect, I'm just reading back in my head how that came out. The question I have is, do we expect to see any like downturn with this? I mean, you know, when you talk about things like the 1918 Spanish flu, that still shows up every year in the flu that is going around, like some part of it. So is this going to be one of those things? Is this going to be like, you know, that's pretty much it, where it's here to stay, and you know, there's no way of eradicating it. Seems like we can't get ahead of it necessarily yet. But you know, on your side of the ball, you must be hearing a lot about projections, right? With what you do in your work, Harry. Are you hearing anything like, you know,
There's
anybody
not a lot of projections.
still just kind of chasing?
It's, well, I mean, yes, there are projections, certainly. But the weight of the current burden is you know, is such that we don't spend a lot of time talking about that. It's more kind of the individual hospitals are talking about staffing and trying to figure out, you know, what do they anticipate based on the trends that they're seeing. Whereas we're talking about it in terms of, you know, available beds and how can you rebalance the beds so that, you know, people are not spending too much time spending hours and hours in the emergency room.
Right.
And
Just
get
experience that.
right. I'm so sorry. I'm so sorry.
Okay.
It's just so hard.
It is hard.
Yeah. I mean, yeah, it's not going to go away. We lost all opportunity to do that. And you can go back and look at the articles about it's St. Louis, and I always forget the other community. There was St. Louis and another community in the 1918 flu, and one did you know, isolation and masking and kind of just shut things down, and another chose not to. And the one that you know, did the full deal managed to eradicate it, and the other did not. And because people travel, you know, if your neighbor doesn't follow, then, you know, it doesn't work out as well for you.
I think one of the problems with COVID is that, you know, what happens with influenza is it mutates every year, and it follows a pattern where the new mutation happens in Asia and the Southern Hemisphere. And as soon as we understand what that mutation is, they make a vaccine, the annual flu vaccine, for that mutation. It's kind of a slow motion process. You know, you know what's coming, you create the vaccine, you have a few months to do it, and then you vaccinate the population in North America, and you try to keep it down. The problem with COVID is that it's widespread and it mutates randomly everywhere, very quickly. And so if one of these mutations, you know, like Omicron last, you know, winter, takes hold, you know, it overwhelms your ability to get a vaccine that can fight it. And so that's what makes COVID particularly bothersome. And so I think it's going to be with us forever, but I think what makes it a little bit more difficult to manage and surge-wise is because it can mutate anywhere in the world at any time, and may overwhelm the ability of vaccines or previous immunity to fight it. And so it's a very unique type of virus that way.
Yeah. Do you guys follow any of the geneticists or immunologists on Twitter or any other social media? They're able to keep track of some of these mutations, and it's just so interesting because they talk about like which one they think might have, you know, preference over others, but it evolves so fast they just don't know, you know what I mean? So it's really, I think it's fascinating to follow.
Yeah.
Does anybody follow John Campbell in the UK?
No.
He's a PhD and a nurse. And what he has been doing every day, he does a podcast, and it's usually on mostly on COVID, but he does other things as well. But he researches, he does like a meta-analysis of all the articles that are out there. So he kind of vets everything for you. And he tries to be very fair in his reporting about it, tries not, and for the most part, he does, I think he's pretty successful. He is pro-vaccine, but he actually was holding out on this most recent vaccine because 2 of the variants have pretty much gone away. So although I think he's still getting the vaccine, but if you're interested, I have found him a pretty reliable source, and he uses John Campbell, and he's in the UK.
It just goes to show how difficult it is to know how to prepare for what's coming.
Right.
Exactly. And that's our challenge.
Dr. Lopez, I just sent you an email.
Oh, okay. So I'm not, as I started this conversation, I don't think we were going to reach a conclusion, but I think some of the ideas and comments here feel helpful in terms of fashioning how we should approach this. And let Carrie say the last word here, but I'm just going to wrap this up. Go ahead. Carrie.
Sorry, I didn't. It's a fascinating conversation. It's a really important conversation, and I just didn't get a chance to talk. My politeness kind of put me at risk.
It would not be without it.
So, I mean, I guess so I would say just a couple of observations. When we talk about the hospitals, Rick, I think that's an interesting thought, but I really would challenge that we need to incorporate Boston hospitals, because I think we seriously on the number of people in the community who receive care at the Boston hospitals, and to only rely on the ones immediately surrounding us would be undercount. There have been some conversations about how do you find the hospitals and tie into communities with other groups. So I think that's a really important piece. There are awful lot of people that go to Boston for their care. In terms of the, I think we had a great conversation about the severity and the transmissibility, and Jerry, your point about the data being so much more precise now is a really important point that I would hope Ade and team might be able to see if they can start sharing some information about that before anything, just what is the data telling us now and why is it different? Because it helps people understand measures a little bit differently. But I think here's what I think. I think, yes, we need a trigger for meetings. And I don't disagree, Rick, that maybe an automatic trigger of any requirement would be too much, but a trigger that we have to have a meeting. And I want to talk about what that might be, because I wouldn't necessarily want it to be, we go to do we go to high? I think that's a little broad. But I do think that is warranted. We have a meeting and we kind of discuss. And I just want to go back to, Kevin, you had said something about, the impact, right? The impact of masking versus not. And I think that's the challenge for public health, is that our work, our success comes from the absence of disease and the absence of illness. So successful restaurant inspections mean that no people show up with food poisoning or other things. And you can't measure that, right? I suppose you could say, you could you could try and gather data and count how many people had meals in Reading at all of the different restaurants and how many cases, but to calculate that would be really hard. So I think that's a tricky thing. It's kind of like speed limits, right? Speed limits, they say speed limits are protective for preventing accidents and but it's same thing. There were no accidents. It doesn't necessarily, I don't think that it necessarily gives us what we want in terms of, looking for that impact. I don't think is something that is easily done. And just because you can't easily count it doesn't mean that it's not there. So I think that's what we really have to tease out. Because if we said, okay, you're gonna have a speed limit of 35 versus you're gonna have a speed limit of 50 on Haverhill Street, what's the impact in terms of accidents or near misses or the like. So anyways, but I just want to, so here's what I think when we're talking about this kind of stuff is I go back to what's our purpose. And our purpose is, we're considering the welfare of the entire population. We're not considering individuals. We're considering the entire population, in the never agains and the yes pleases. It's our job to protect from the spread of infectious disease. That's a key point of what we need to be doing. And it's also our job to be making sure that we are ensuring access to safe and quality care. And that's where COVID kind of gets us on both sides, because it's the spread of infectious disease, and it's also the access to care as hospitals, as care isn't available. So those are the things that I kind of consider when we are making these things. So yes, please, a trigger. Can we talk about what would be the trigger? And okay, we'll talk next time. Look at you smiling at me a day.
Go ahead. Sorry.
I'm done.
Well, yeah, I would be more than happy to call a board meeting if board members, feel whatever the conditions are, whatever data we want to look at, that we're heading towards something that we need to address. And we don't need to be, fixed in terms of, our monthly board meetings. So I'm not the only person that would be calling these. I would hope that if, Jerry or Carrie or Kevin or Paula feel, we ought to have a meeting because this is happening and this is happening, we'll do it, But I agree, we don't want to be put in a box around what we have to do. And I feel like so much of this is all judgment, and it's hard, it's hard because the answers aren't always clear.
Mm-mm. Part of the fun of the field.
Yes.
Yeah.
All right, so I'm gonna move on, if we may, to item number 8, which is the Article 11 at the town meeting. So, as you recall, we asked the select board and Fidel to work on ways to increase the full board membership from 3 to 5. And that was one of the recommendations of MAPC. And as a result, the select board agreed and put forward an article, Article 11, that will be discussed at the town meeting next month, that if approved, would allow the select board to petition the state legislature to enact a special rule to allow this to happen, potentially by next spring. The other alternative would be to wait till the town charter is revised, which I think is in 2 years or something. And so Fidel asked me if two things. One is, could I write up a little piece that's an explanatory piece for town meeting members that would go out with their packet a couple weeks before, whenever they send out the meeting information that explains Article 11. And so I had sent this to board members, and I'm going to Once again, share my screen. So this was what I sent, and basically what I tried to explain was that, you know, there are two laws that intersect and create problems for us. One is Chapter 111, which created the boards of health, but says there needs to be at least 3 members on the board. And then there's the open meeting law, which says anytime you have a quorum of public bodies, you know, whether it's on a phone conversation, email, in person, it has to be posted as an agenda, as a formal meeting. Because Chapter 11 only allows us to have 3 board members, that means no 2 board members can talk together, which creates, you know, particularly I think with COVID, tied us up in knots in terms of our ability to communicate. Not that our intention is to, you know, make decisions behind closed doors, but really just to have clarification, follow-up, feedback. Currently, every time we do this, we have to, you know, go through the health director to collect stuff, and it really ties us up. So what I listed here was it would be better collaboration. So for instance, you know, for this RFP process for the community health needs assessment, we can't have 2 board members on the selection committee, you know, because that would be a quorum. And there were similar problems with incident command and other things that really made it difficult. I think the second point I tried to make was that around the communication offline, which is just a natural way of doing things. And I think lastly, you know, I think the associate board members put in as much time and energy in terms of the board work, and for them not to be able to have a vote sort of seems unfair on the face of it. And so, and there are other towns, which I listed at the very end there, that, you know, currently have 5 members. I actually had a conversation with the chair at the Winchester board a few months ago, and she's looking at exploring the same option. So this is going to go out. So there were 2 items I wanted to just raise at our meeting tonight. One is, if there are any comments, or, you know, did I capture the main reasons why this is important? But if there are any comments, if you can send them, can you send them to me? or raise them now, and, you know, I can always edit this. I don't think the packet's going out for another week or 2, so there's plenty of time. So yes, Carrie.
I would just suggest that you add the town meeting as a body passed an instructional motion in I'm not sure of the year now. It was April. It was Springtown meeting. There was an instructional motion to recommend an increase of the number of board members, and that was passed unanimously. And that's an important reminder to the body that they were in favor.
They already did that. And what is that called? An instructional?
There was an instructional motion. It was actually presented by Emmy Dove, past chair, and supported by other members or past members of the board. And it was, and Kevin, do you remember what year it was?
It was this year, Carrie. It was back in April.
Oh my
Okay.
God.
Good. I will.
A lifetime ago, but
Yeah, no, it does.
but yeah, so that's an important addition. You know, I mean, it's a thank you to the body for the instructional motion, and just reminding you that you did,
Okay.
and here we are.
Good. That's helpful. I'll add that. Yes, Kevin.
I'll add in just a couple of things. I think the emphasis, you know, part of what I'm going to get up to speak at as a town meeting member is I'll have to go back and look at the dates. But to your point, Rick, we met for 14 or 17 straight days at the beginning of this whole thing, because 2 people couldn't speak to each other. So we were calling meeting after meeting after meeting after meeting after meeting. Like you said, just to say, okay, what's going on today? What can we do about it today? What's the information we're getting today. And I think that's a big part of this moving forward, right? Like, let's not expect that we're never going to come across this situation again. That'd be foolish. The one thing I will say, though, I think your number 3 topic, I'd reword that a little bit.
Okay.
If I was against this, I would say, yeah, but you're still going to have 2 associate members, so it's still going to be unfair.
Right.
Right. So never leave an argument out there to be had, as I always say. I think the point of this is to say, there was when COVID first started, we had a wealth of people that wanted to help out in some capacity, and they weren't, mostly because we were meeting almost every day and 3 days a week, they weren't willing to commit to what we were doing at the time. But we're not there right now, and it'd be great to have those professionals back in there with insight. I think that's one of the big components too, right? So it's not only adding our ability to operate and function better, but it's adding our ability to have more opinions in there from the medical field. I think that's huge.
So this is kind of a twist that I wasn't thinking about. So I was thinking that the 2 associate members become full members and there's a 5-member board. What you're saying is there should be a 5-member board plus the additional 2 associate members. Is that what you're saying? Like a 7?
Yes, because that's essentially what it would be.
Okay.
Now I'll check myself on that. I'm not sure if it's a requirement for every board to have 2 associate members or not.
I suspect I don't know when the associate member status was added, but I suspect it was, as you said, to get more perspectives and more opportunity for input.
Well, you know what it really was? It was for folks that aren't necessarily want to be full voting members, i.e. I'm committing to being at every meeting, at every vote, and understand on. But I have some interest in this board, and I'd like to, slowly ease my way into it. So it was brought up as a way for, okay, you don't feel like you're ready to be a full member? Great. Be an associate member. You want to have a voting role. You can learn everything about this board without, feeling that pressure. And then if you wanted to move up if a seat came available, you could. And that was really more the essence of why we did associate. So I would definitely keep, I'd have a 5 voting board with 2 associates.
Does everybody else, Paula, you had your hand up too. Does everybody else?
That was my exact question too. That was about the keeping the associates with the 5-member board.
Getting really nervous right now. Can you guys sign a disclaimer statement somewhere?
You're so easy to manage a day. Come on.
A disclaimer that you won't conspire to undermine the position and the authority of the health director. Can you put that in there somewhere?
That's right. Yeah, it's a joke, but it's a little.
Hey,
I know,
but it's a possibility.
It's unfortunately a very real possibility. Not from us.
We're
not going to do that. But
yeah, I'm not trying to be a figurehead director.
Nope.
That's not what I'm trying to be.
Nope.
So actually, number 3 here wouldn't make sense if, in fact, we wanted to go to a 5-and-2 format, because we're still saying there would still be 2 associate members. So
right.
The question is whether I should delete that or not.
I mean, you could say it's more opportunity to be involved in a town, committee, because we would go from 5 to 7.
Yeah, I think you could keep the second piece of it, and maybe the fairness to volunteer.
Eliminate that. Yeah.
The board member recruitment, opportunity to increase involvement and more opportunity for those smart folks to weigh in.
Okay.
I think it's a better opportunity to increase the breadth of knowledge on the board, right?
Yep.
Not that the board is knowledgeable, but the more voices in the room, to a point, the more voices in the room, the better. the more eyes to look at something, I've always thought you come out with a better product that way. Three is a difficult number, even though we operate as 5, but still.
Okay.
We're lucky to be able to operate as 5.
If you have any other comments, I'll make those changes and maybe get it out to people. And I'd like to try to get this to Fidel by next Wednesday or so, a final thing that he can send out. The other issue or question that came up was needing to have someone present Article 11 to the town meeting. And you know, I had sort of checked in with Carrie and Kevin because they're both town meeting members, and they had differing perspectives. Surprise. But
Same perspective.
well, actually, so one thing I suggested, well, either Kevin or Carrie could present, or both, since you're at the town meeting. Kevin's perspective actually was maybe I should do that so that Carrie and Kevin could independently stand and voice support from the meeting, that, you know, that they're supportive of this. You know, I'm sort of, I can go either way, but you know, it makes sense. It makes sense both ways in some ways, because I think hearing from town meeting members is powerful. Sounds like, given the instructional motion from last April, this is not going to be contentious, but.
In my rationale really for that, Rick, was more just getting another voice in the room. If you don't present, you're not a town meeting member, you don't really get the opportunity to speak until every town meeting member has spoken. If you want to sit in the way back and wait and raise your hand, and it hardly ever, very rarely happens. Usually it's a call for a vote well before the last hand has been tried to raise, so to speak, and you'll never get the opportunity.
Right.
If you present it, now you have another voice in the room, and then Carrie and I can raise our hands.
Yep.
That was my rationale.
Yep. And I'm sorry if I thought I was playing along, and it sounded, I guess maybe I missed something, but
No,
I was going for the yes. So
I'll follow up with Fidel. I mean, I'm happy. I know there were 4 dates and 22 articles. And so I hope you love being a town meeting member, sit through 4 nights like that. But in any case,
it is also commonplace, Rick, just so you know, this is not breaking from the norm. It's very commonplace for the chair to present.
Okay.
yes.
You know, across all the other boards, any other board that's presenting an article. So
Okay, I'm fine with that.
And they usually, I think they can handicap for you which night it will be heard at. You don't have to come sit with us, although you're most welcome to.
yeah, you don't have to do 4 nights.
We enjoy it. Yeah, we enjoy it. And I see Carlo nodding. Yeah, that you can kind of predict what night the article would be heard. So that
Yeah, Fidel said he would kind of let me know. Although wasn't there a town meeting that went the whole meeting talking about one particular article?
probably.
Last April, last fall, and it just kind of went on to the next night. Amazing.
Well, that will happen again. Trust me, that will happen again this year.
You can never tell exactly.
All right. Kevin, any updates from the coalition or?
There's no updates from the coalition because, as you remember, they were having normally they have a yearly kind of more like a event more than a meeting for their September meeting. This year they were down on the town common. They were holding their Recovery and Remembrance event, where they had different segments of the night from 6 to 7:30. They had different segments on the common, what they were doing for that event. Unfortunately, I had to go work last minute and I was not able to attend it, but I heard it was a very successful night.
Yeah.
So,
It was actually, I went.
oh, did you? Oh, great.
Yeah, it was very well done. You know, they they laid out these sort of stories, individual stories from all the towns of individuals who, you know, overdosed from opiates, and it was very, very moving. And then they had some speakers, and then this candlelight vigil. It was really, really nice. Erica did a good job putting that together.
Yeah, actually, Kerry just brought up a good point about Erica did receive a. Could you? I can't remember for the life of me off the top of my head right now. Kerry, do you have it?
Yeah, it's the
Prestigious
Gomes.
award.
Yeah, it's the Gomes. It's the Peter J. Gomes Service Award for 2022, and she was one of 4 finalists, and she was named the winner, I guess. It's a service award recognizing commitment to community and exemplifies qualities of integrity, compassion, and unwavering commitment to their community. And it's named in honor of Reverend Peter J. Gomes. It's something that actually Representative Moulton, Seth Moulton, sponsors this award for his district. And yeah, it was
That's
a really
wonderful.
wonderful. It was really wonderful. Erica really
Well
is
deserved.
such a professional. Yeah.
Really
Good for
deserved.
her. Well deserved, yes.
All right, Ade and Mallory, the department report.
So, 365 Ash Street. The only update that I have is that the owner has been discharged from the hospital, and his children are working to find him a hotel. At this point, I do not have any information about his whereabouts. 34 Hatchon Street. Things appear to be moving in the right direction. Jennifer and I were there today. We observed some fresh mulch on the ground. Lots of weeds have been removed. It's looking good. It appears that the cleanup activities are still ongoing. I am comfortable at this point with suspending reinspection activities for now, and possibly resuming those activities in the spring or early summer. We had a good conversation with the homeowner, and he pretty much assured us that he will do everything possible to maintain the yard, and even if we don't show up, he will keep working to make sure the yard is in a good and well-maintained condition. So if we go out in the spring or early summer and everything looks fine, we'll be recommending to the board to remove the provision to hire a licensed landscaper to help him out with the yard, because at that point he would have been able to demonstrate that he is capable of taking care of the yard. So that will be my recommendation if everything goes well in the spring or early summer. All right. In the month of September, we conducted 16 food establishment inspections. That was primarily done by Jennifer. We also conducted 3 food establishment re-inspections, one at Market Basket, another at Venetian Moon, and one at a Mandarin. We responded to 3 food complaints, one at Market Basket, Starbucks, Burger King. We responded to a housing complaint at Reading Commons. It was about a water leak underneath the sink. We added a new food permit for Niji Sushi, and we had a closure at Green Tomato. We had 1 septic abandonment inspection at 201 Van Noorden Street, and we got multiple rat complaints on Auburn Street and Longfellow Road. We issued 17 temporary food event permits, and they were all issued for the Fall Street Fair. Let's see, what else do we have? Jackie, could you please pull up the rodent map? All right, so with the help of GIS coordinator, Matt Dean, we were able to come up with a preliminary map of rodent activity within the town of Reading. So basically what we did was we generated maps for um, each temporary dumpster in the town of Reading, each annual dumpster, all the sewer pump stations, stormwater networks, sewer networks. And once we created those maps, we superimposed those maps on each other. And then we added the areas where we got rat calls and rat sightings from. So pretty much our intent was to get some kind of correlation, what is causing an increased rodent activity in the town of Reading. But the data is limited at this point. We don't have all the rodent sightings included in the map. So we're working on getting all those sightings and all those addresses. Right now, I would say that it is inconclusive. We can't really find any correlation except for a cluster around Longfellow and Auburn Street. Jackie, would you be able to zoom into that cluster? Yes. Yes. So if you look around this area, we got a few calls from here, and we can inconclusively attribute this cluster to the construction work going on at the water tower.
Mm-hmm.
And so what we've done is, Jennifer and I visited the construction site. We pretty much identified some issues with the rodent remediation techniques, and we ordered them to pretty much increase their bedding and rodent remediation techniques from once a month to twice a month. And we're hoping that that would help alleviate the rodent issue in that region. The main goal for doing this is to figure out a comprehensive plan. So we know that we will be getting more calls. So we want to stay proactive and pretty much have a plan ready so that once we start getting those calls, we can act immediately. So this is still ongoing. It's a work in progress. We urge residents to let us know if they have any rodent issues, or if they have if there are rodent sightings, they can inform us and we'll plug it into the map and try to see what we can do about the issue. I have a meeting next week with rodent control contractor, Yankee Pest Control, and we will be trying to figure out other ways to mitigate this issue. We know that a pair of rats, a couple, within a year can multiply and produce 15,000 offsprings. So now the choice is, do we want to go with a technique that kills the rats, or do we want to go with a strategy that stops them from multiplying? I would think that going with a strategy that stops them from multiplying will be the best way forward. Or we can do a combination of both. So they have something called the birth control for rodents. Mm-hmm. So it's really expensive. I have experience with that, and it cost us I think it was about $80,000. So it is really expensive. We're still weighing the options, and eventually, and hopefully, we would come up with a comprehensive plan to deal with this issue. Let's see. That's pretty much it. I will now defer to the public health nurse, Mallory, to provide updates on disease surveillance, reporting, and control.
Can I just ask one question? Based on your experience today, is that that number of rat sightings, does that suggest a major problem, a minor problem?
Well, we don't have all the data. For example, we know that they had issues at the high school, but we don't have data from that. We know of some other prior complaints about rat sightings, but we don't have that data at the moment. So
You
we're
don't
working to compile the data, plug it in the map, and hopefully if we can find some correlation, that will give us a starting point in terms of developing a comprehensive plan.
Thank you. Sorry, Mallory.
Hi, everyone. So in the last month, let me pull up my report. So the COVID numbers are, we've discussed them, they're staying pretty much the same. Most COVID numbers are 18 years or older. The deaths are exactly the same. There's no clusters besides households, which is what we expect. Other diseases, we had 3 cases of malaria due to traveling outside of the country and not taking prophylactic medication. That happened the last month. 3 cases of Lyme disease. 1 case of, I cannot say this word, urinosis. We investigated it, and with the help of Jen, we discovered it was from the person not cooking pork properly, and sadly getting sick from it. And we had 1 case of the influenza. So for this flu season, I've started vaccinating. I started with Pleasant Street Center, the senior center. I got 43 vaccinated. We went to Frank Tanner and we had 26 vaccinated. Town Hall, 19, the fire department, 30, and the police department, 21 vaccinations. Next week, I will be doing Cedar Glen and the DPW, and then we'll be opening up to public vaccinations for the city. I'm going to do 3 years or older in the library, October 19th. We're talking about another opportunity, hopefully Monday, the 24th. Just because when I put it out, it booked up so fast, I wasn't expecting that. So I want to do another opportunity for everyone to get vaccinated. We also have a clinic hosted by Vaccinate RX on the 28th that will do bivalent boosters and flu vaccinations. And their numbers are as followed. On September 16th, they had 2 Pfizer's 3 to 4 years old, 11 Pfizer's 5 to 11, bivalent boosters 72, Moderna boosters 30, regular flu 95, and then high dose flu 6. And then on the 30th, they had Pfizer's ages 3 to 4. They had 3 vaccinations, 5 to 7, 11. Pfizer bivalent 75, Moderna bivalent 39, 93 for the regular flu, and 24 high dose flus. And I am going to start preparing to be able to vaccinate children 3 years and older. I'm going to go get a child a pediatric EpiPen with the help of the Somerville study, which will be good for the community.
Great.
Thank you.
Thanks, Mallory.
Thank you. Any questions or? Okay. So I don't see any members of the public online. And our next meeting is in November. One thing I wanted to mention, I think this is Jackie's last meeting. And I would pull my hair out if I had any. But I think I speak to all the members on the board to really thank you for your work. You do amazing notes. You're very efficient. You're very cheerful. And it's just been a pleasure to work with you. And I also enjoy your cats in the background. as
Mhm.
well.
Thank you, Jackie.
Yeah,
And
we're
Jackie's
really
gonna be
lucky
with
to have you this whole time, Jackie.
Oh, and Ringo would like to say hi.
I hope he isn't insulted. I only mentioned the cats.
I didn't
No, he's
know
not
there
insulted
was
at all. He scared them away.
Thank you so much for everything, Jackie. You've
You're
been a
welcome.
lifesaver, especially through the COVID piece. Oh,
Yeah. Thank you so much. We were so lucky to have your services secured for us. It made a huge difference, you know. Trying
absolutely.
to keep all those minutes ourselves and
Oh
kept them-
my God.
it
Oh,
that was a
it
nightmare.
was a nightmare.
was really bad. So thank you. And yeah, you're just great to have around as well. So
It's been
it's a-
my pleasure. Thank you, guys.
And
Thank
Jackie's going to be helping Melissa transition to her new role, which will
Awesome.
be great. All right. With that, make a motion to adjourn. Do I have a second?
Can I vote this time?
You may. You may. You don't have to read
You've
anything.
actually been able to vote the entire time, just so you know.
Second, Carrie. Roll call. Paula,
Yes.
Carrie,
yes.
Rick, yes. Thank you all.
Have a great
everybody.
night. Bye.
Everybody.
Bye-bye.